Now, many of you will either know or have heard of Professor Dame Carole Black. She was one of the original pioneers in scleroderma research and set up the internationally renowned Centre for Research and Treatment for Connective Tissue Diseases at the Royal Free Hospital. No matter what Carole has been doing and whether her career has gone in a different direction, she's always remained very committed to the cause. And so I'm delighted that she is able to open the conference today.
I'm absolutely delighted to be able to open our virtual conference today. Of course, being virtual gives it certain advantages because we can have lots more people attend. Of course, we also miss being with individuals. And so we have to balance the advantages of many, many more people able to join in. And there are the sadness that we lose that individual contact. And I used to enjoy that so much when I attended scleroderma conferences in the past. I go back a long way with the two organizations that have formed this wonderful new society. And I just want to say a little bit about that because their beginnings were very interesting. If I take the Scleroderma Societies to start with, many, many years ago, before about 2 years before its actual founding, I met with a woman called Amy Dean in my house in Ely, and we were thinking about a patient organization. Amy had interstitial lung disease. She was a young woman, a social worker, and absolutely determined to do something for patients with scleroderma. Her dream was to see a functioning and flourishing society. Amy knew that there was no real treatment in those days for her interstitial lung disease, and she died before she could really see what was possible. But she had the vision of a patient-orientated society, and I think we've given her that today. The Raynaud's and Scleroderma Association, its very early beginnings was, of course, with its founder, Anne Maudsley. And I still remember sitting in a lecture theatre. I'd been to a conference and I was lecturing, and Anne was there, and she was talking about how she came to develop her Raynaud's. And here again, we had a woman passionate to make a difference, passionate to make sure that patients got the best possible care. And of course, she founded the Raynaud's and Scleroderma Association and did wonderful work. And now today we have those two organizations merged, and I want to commend and congratulate Sue and her team on the excellent work that they've been doing to bring those two organizations so successfully together. I always wanted there to be one organization. It seemed sensible to me that we should really put all our eggs in one basket so that patients had one organization to go to, because scleroderma is an uncommon condition. And here today, we have that. When I look at the program that you have in front of you today, I think it's absolutely packed with really good things. You're going to hear about changes in the world of scleroderma. You're going to hear about new drugs. And that reminds me that when I started to have an interest in scleroderma and Raynaud's, we really didn't have any drugs that were specific for the condition. We borrowed everything. We borrowed from our renal colleagues, our respiratory colleagues, our cardiology colleagues. We said, do they have drugs which might help us with some aspect of scleroderma? Scleroderma is such a complex condition, and we know there's never likely to be one silver bullet, but that we would have to combine drugs, certainly for the very worst form of the disease. And as you all know, over the past 10, 15 years, we have seen an ever increasing number of drugs being tried for scleroderma, and some of those drugs reaching the regulatory standard that they can go into actual practice. And that is wonderful news. But remember, every time a new drug comes to market, there has been years and years of science behind it. And I just want to make a plea as I talk to you today for the support of science in scleroderma. Of course, there are many things, practical things, that patients need. But really, if we are to get to the basis of this disease, if we are really to make big inroads, then we have to invest in the science. And it may take several years for that science to come to fruition. But drugs are a very good example of that. They start with a scientific idea of somewhere that you can intervene in the disease process, and then that gradual trialing and developing of a drug that can really work. Today, we'll also discuss the use of data. I was trained by a wonderful woman called Barbara Ansell, and what Barbara taught me, that the collection of both clinical and scientific data was absolutely important if you were studying a disease, if you wanted to subset that disease, if you wanted to make correlations. And that is never more true than today. And I'm really delighted that you're going to have a session on the use of data. You also have a session on children and young people. And in the days when I trained, I was allowed to treat children with scleroderma. Today, that would be rather different because, as you know, we have pediatricians who look after children with scleroderma. But in those early days, and this is now, we're talking about the 1970s, I was permitted to treat children with scleroderma. And that was a great joy. And my youngest patient was less than 2. So I really did have the opportunity to treat very young children. And I still keep in very close contact with a young woman who came to see me when she was only 3 years old with localized scleroderma. So thank goodness it was a very local form of the disease affecting her leg. And she and I have kept in touch throughout her education. She's grown to be a wonderful a young woman, now holding down a really, really a good job. And we get together regularly. And I'm still in contact with her parents. So one of the great joys of being involved in scleroderma is that patients still keep in contact with you. And I still have patients who write to me. The other thing you're going to discuss today is the GI tract. And of course, that's always been such a challenge to us, whether it's the top of the GI tract, the esophagus, the middle, or the bottom. We still have a long way to go to really be on top of that. But it's wonderful that we have gastroenterologists that will work with us to really give the best possible care that can be given to patients who have the really miserable complication, either in the esophagus, in the midgut, or in the lower gut. I believe SRUK is growing stronger all the time, and that is wonderful to see. I want it to become more visible, and I think as it grows in importance and as it collaborates with other specialties, I would like to think it will increase its advocacy role to the top of government, because we will need government support, the government agencies support, their arms and bodies support, to make sure that the drugs we are developing are indeed available to patients with scleroderma. So I really hope you have a wonderful conference. I know you've got breakout sessions. There's so much to talk about, But let me tell you, compared when I first got interested in this disease, which as a very young doctor, when I cared for a young woman who had scleroderma in the kidneys, terrible diffuse disease, admitted as an emergency when I was really in my first job as a houseman, and who died under my care 3 weeks later. I felt determined that there should not be a disease where we knew absolutely virtually nothing about it, and when we could do so little for patients. I wanted and was determined at that point in my career that if possible, I would do something for scleroderma and make a difference. And now I can see a flourishing of that dream with so many people making that difference. And SRUK is a really important part of that. So thank you very much.
A massive thank you, Dame Carole, for your wonderful welcome, and also for sharing some of that rich history that's helped shape SRUK. As Dame Carole mentioned, there have been significant advances in scleroderma research over the last 20 years. But as Carole often says, we've come a considerable way, but not far enough. And it's no surprise, therefore, that this topic of new research and what are the new kind of treatments and therapies in the pipeline is always one of the most popular ones at our conferences. And I'm delighted that Professor Chris Denton has agreed to give this keynote speech addressing these issues. Chris is extremely well placed to share this. He's a consultant rheumatologist at the Royal Free Hospital, and he's also Professor of Experimental Rheumatology at Imperial College London. As I said earlier, we will have an opportunity, and please do take it, to ask questions, put your questions in the Q&A, and we'll come to those at the end of the session. So Chris, the virtual stage is now yours.
Thank you very much, Sue, for the introduction. And it's a real pleasure to be part of this fantastic program for this virtual conference. And of course, as we're now sort of fully accustomed, I think, to doing these meetings in the pandemic era, we've realized that it's nothing like meeting face to face, but there are some strengths to doing the virtual meeting. And one, of course, is the reach. And it's fantastic that people are able to join really from around the world. And I think that's important for scleroderma because we're very much a global community. So as Sue indicated in the introduction, it's always a challenge to talk about latest advances in research in systemic sclerosis. I really value the opportunity to do that and to share it, particularly with SRUK, who've been really very supportive of all of the work that we've done in our centre over many years. But what I wanted to do was to really share with you some of the advances that have happened and what we've learned from research, and what I've personally learned from studying scleroderma now for, in fact, more than 30 years, but 20 years as a consultant here at the Royal Free, both looking after scleroderma patients, but also working closely with research colleagues to try and better understand the disease, and most importantly, keeping the patients really very much at the centre of what we do, to use that advanced knowledge of understanding scleroderma to hopefully develop better and more effective treatments. So I've divided the talk up into two topics, two parts really, sort of what we've been learning from research, which really I've focused very much on what we've learned about why and how people develop scleroderma, if you like, the cause of the disease and the mechanism, and then how we're, for the second part of the talk, how we're developing that knowledge and using it to both test and, if you like, prove the treatments that we're already using, but also move to the next stage of developing new options. So I'm going to start really with what I would say is quite fundamental science of scleroderma. And I would like to highlight that maybe 30 years ago, we really had very little idea about how scleroderma developed, what caused it, and what the fundamental mechanisms were. I think because there have been a lot of advances in biology over the last 30 years, and a lot of focus on the disease, we are in a better place now. And so I'm going to start off with that very sort of important question that many patients ask us when they develop an uncommon disease like scleroderma, why have I got it? So when we think about the cause of scleroderma, we do have to remember a few key features. It's an uncommon or rare disease affecting around 1 in 10,000 of the population. So the first thing to think about is that whatever causes the disease, clearly it occurs relatively infrequently. We can also learn something just by looking at the patients that get scleroderma. We know that on average, although it can occur at any age, it typically has its onset in what I would call as the peak of life, but in the sort of between 50 and 60 years old. The majority of patients are female, but interestingly, we know that if you're a man who gets scleroderma, sometimes you're more likely to have more severe disease. And we know that certain ethnic groups have a worse outcome. We know that Black patients, Afro-Caribbeans and Black American patients seem to have a worse outcome. So that's important because it tells us that there are certainly features about you that in a way make you susceptible to the condition. And that does come back often to genetics. And so I'm going to talk a little bit about the genes that we've learned about what the genetic aspects of scleroderma are. But we also know that something has to happen to you when you are susceptible. And that can perhaps be seen most often as an environmental trigger, but in fact it's a bit more complex than that, because it's probable that to develop a disease and for the disease to progress, it's probably a series of triggers that occur. But we know that certain chemicals and other aspects of the environment, and including the environment in your body, the microbiome, the bacteria and organisms that live in our gut and our lungs, these can all be relevant to whether you get the disease. But of course, if you've got the genetic susceptibility and the trigger, chance has an important part to play, because if you don't get exposed to the trigger at a time when you're susceptible to develop the disease, you won't get scleroderma. So all of these things have to be factored in. And if we're thinking about the journey as a patient develops scleroderma, this is really probably something that happens throughout a patient's life, that they start off with some sort of genetic susceptibility, and then things happen to them through their life at different stages that may trigger Raynaud's phenomenon, and then they stimulate the immune system to get autoantibodies, and then start to trigger the early features of scleroderma, what can be diagnosed perhaps as very early scleroderma or VDOS, and then the full-blown disease. But of course, then there's what happens once you get scleroderma, what determines whether you get lung fibrosis or heart involvement or bad calcinosis. All of this is probably also related to factors about you. And so to try and understand that, like a lot of diseases, we've really tried to study the genetics of many, many patients with scleroderma and see what's different about them compared to healthy individuals or people with other conditions. So I'm really pleased that we are at a stage where I would say we've really, I think, answered a lot of those questions. And the way we've answered is by applying the modern techniques for genome sequencing, for genetic sequencing and analysis, and also by a lot of collaborative effort from groups around the world, because the challenge is that scleroderma is rare. And you often need thousands of patients to fully understand the genetics of a condition. So this plot is taken from a recent paper published by a collaborative group, scleroderma genetics, led by Javier Martin in Granada in Spain, but very much a group effort from the United States, Europe, and Asia. And I would say this summarizes what really is probably the truth about genetics in scleroderma. It tells us that different genes can contribute to whether you get the disease. And there's a particular peak in this plot that's called a Manhattan plot, because it's a little bit like looking at the Manhattan skyline. This peak is on chromosome 6. These are the genes that regulate the immune system. So we know that it's an autoimmune disease, but there are lots of other genetic aspects as well that are important. And you can start to put these things together. So these are data that have come from 9,000 patients with scleroderma compared with 17,000 people who are healthy. And it's allowed us to sort of work out what the genetic landscape is. And we can come up with what's called a genomic risk score. So you can work out whether a patient has a high or a low risk of developing scleroderma if they're exposed to a particular trigger. Now, this is not something that's ready for the clinic, but it does tell us that and help us to understand the disease. But what we've also been able to do is to look a little bit in more detail at the genetics of the immune system. I showed you that really tall peak of genes on chromosome 6. And these are the genes that regulate our immune system that we use to fight infection, to fight tumors, and very relevant. And this is the part of the immune system that generates the autoantibodies in scleroderma. So not surprisingly, we've been able to show that there are different genes in the immune system that determine which autoantibody you get in scleroderma. And we know that's important because the autoantibodies, as I'll show you in a minute, can determine, in a sense, what happens to the scleroderma once it develops. So we understand that aspect of scleroderma in terms of the common genetic variation that helped us to understand why you might develop the disease. But it's a little bit more complex than that, as I said, because once you've got scleroderma, we'd really like to know, well, why do you get a particular complication? And we've done some work, and this is work that was supported in part by SRUK, to understand if there's a genetic susceptibility to whether you might get a scleroderma renal crisis, a very important complication of the disease. And when we did this, what we took was a group of patients who had a high risk of renal crisis because they had diffuse scleroderma and an anti-RNA polymerase antibody, an antibody with a high risk of the complication. But we had followed these patients for a number of years, so we knew that half of them had a renal crisis and half of them hadn't. And so just with 100 patients, rather than the 9,000 that we needed to sort of understand the general disease, we were able to really, I think, make some progress to understand why you might get a renal crisis. And we found two genes that were particularly interesting. One of them is a gene that was already known to be associated with hypertension, with high blood pressure. So it does seem that if you've got a tendency to high blood pressure, you are more at risk of getting a renal crisis. And that was important and interesting. But we also found this other gene, delta-2-catenin, which is involved in the pathway that regulates the way that blood vessels recover from damage. And I think that this, again, is something that's been associated with scleroderma pulmonary hypertension. But when we looked at scleroderma renal crisis samples, you can see in this tissue slide, in this recent publication, that the red stain is this protein that's expressed at high levels in the renal crisis. So again, it helps us to understand a bit about the disease and why patients get renal crisis. But what about those environmental triggers? So we've known for many years that certain chemicals can trigger someone to get scleroderma. This was first apparent from an occupational exposure to vinyl chloride gas, so vinyl chloride monomer, a colorless gas used in plastic manufacture. And it was appreciated a number of years ago that patients working with vinyl chloride could get connective tissue diseases with features of scleroderma. And this is now well recognized. And so it's not really seen because we take all of the precautions to avoid exposure. But it tells us that chemicals can trigger scleroderma in someone who might be susceptible. And we see the same thing. We see it with cancer chemotherapies, as you can see in this X-ray, and we see it in these skin pictures of a patient who was exposed to a solvent that was used to clean metals. And he developed scleroderma within a few weeks, and as did someone else who worked in the same machine shop. So really, this was sort of quite a strong proof that this chemical could trigger the disease. So that's, in a sense, why you get scleroderma, triggers and susceptibility. But how does it happen once it starts? And this is really understanding the mechanism. And this is perhaps more important because we can't really prevent the disease, but if we understand how it develops, then we can perhaps advance therapy. So again, we know that it's an autoimmune disease. I showed you the immune genetics. We know that many patients have autoantibodies if they've got scleroderma. And we can think about what we know about the pathology, what goes wrong in the tissues. We know that there's fibrosis or scarring. It's a disease in which the skin gets hard and thickened and the lungs can become fibrosed. We know that there's inflammation in the skin, particularly in the early stages, and we know that the blood vessels get damaged. So if you put together the fibrosis, the inflammation, and the blood vessel damage, you can start to think, well, what other biological processes involve these factors? And in fact, it's tissue healing. So just as it might be seen that autoimmunity is almost an inevitable consequence of having to have an immune system to fight infection and maybe help us to fight cancer, that having a system to repair tissues that are damaged is clearly biologically fundamental. But because it's a complex process, of course, it can go wrong sometimes. And so perhaps the best way now, I think, that we see as a model of how to understand scleroderma is that it's a disease in which the normal repair processes for tissue that are damaged have gone wrong and they've sort of gone out of control. So I just put this up as a sort of statement, really, of how I would say over the last 20 years my perspective has evolved. So that I would say that now scleroderma, if I was asked what the disease is, it's really a disease in which there's abnormal repair of connective tissue with excess scar formation and a failure of the normal processes that help scars to soften and resolve over time as they would normally after an injury. So with that in mind, we can start to see, well, can we understand that scarring process and why it's not being switched off? And I just, again, highlight this one data slide because it's from a very nice study, again, supported by a grant from SRUK. And this work was led by Emma Derrett-Smith in our unit, working with Christina Clark and others. And I just wanted to sort of highlight that what we know is that although we realize that scleroderma is a very variable disease, some people have localized scleroderma or morphea, some patients have systemic disease, systemic sclerosis, that there is actually a very small number of patients that have both conditions. And this was particularly interesting, we thought, because we wondered if we could learn something from the morphea lesions in those patients who'd also got systemic sclerosis. And so we found a small number of these patients that had morphea and systemic sclerosis. We biopsied both the scleroderma skin and the morphea skin, and we compared the gene expression. It was very helpful because it allowed us to identify those genes and proteins that are really driving the fibrosis. And again, this has been something that we've been able to confirm in other studies. So it's really about using the patients and what the patients can teach us to sort of really understand the complex biology of the disease. And that brings me to the next concept, really, because we do know that systemic sclerosis is a very diverse condition. I know that many of the patients who have joined us today will be quite different, but there will be general patterns of the disease. We know that some patients will have limited cutaneous disease, what used to sometimes be called CREST syndrome. Not a mild form of the disease necessarily, but certainly with less extensive skin fibrosis. And then other patients will have the diffuse form of the disease with very extensive scarring and fibrosis, particularly in the early stages of the disease. And I will also be aware that about a fifth of patients will have an overlap syndrome. So they won't just have systemic sclerosis, they'll have some features of lupus or Sjögren's or myositis as well. And the fact about having a disease that has obviously got shared features but also differences between patients is that this also gives us an opportunity to perhaps better understand the condition, because we can look at those different groups of patients and say, well, what's different between the patients who get those different complications? So again, I just wanted to highlight just this one figure from a paper that we published at the end of last year that I think was a landmark paper because it showed that you could predict quite early on in the course of scleroderma what the risk was of developing a particular complication, for instance, as shown here, lung fibrosis. So if they had significant lung fibrosis, you can see you could categorize these different groups. If they had diffuse skin disease, that was more likely, but in particular, some of the antibodies gave us a strong association, particularly, for example, the anti-SCL70 antibody. So this is helpful because it means that we can categorize our patients early on in the disease and at least know to some extent what their risks are, which is important when we're looking after them, but also important for biology. So fueled by that sort of concept of trying to use the diversity or variability between our patients to actually help us understand the disease, we embarked a few years ago now on what's now a study that's really starting to deliver, I think, a lot of interesting results, and that is the biopsy study. So the biopsy study was a research collaboration with research and development at GSK, not to test a drug, but just to try and better understand scleroderma. And what we did was we took skin and blood samples from a well-characterized group of our patients who volunteered to be in the study. And we compared diffuse scleroderma with limited scleroderma and with early and late stage disease and with healthy controls. So we took lots of skin biopsies and blood samples. And we've started to now analyze these results. And it really has started to be very interesting because it means that we can start to understand what is the difference between a patient who has perhaps got a high risk of developing lung fibrosis or getting more severe skin disease compared to a patient who's at lower risk, and what's the difference between a patient who's just got limited scleroderma or one that's got late stage disease where the skin has improved. So by using these complex biological methods of looking at gene and protein expression, we've been able to sort of understand the difference between the disease. But this would only make sense if we could start to use those sort of molecular approaches in an unbiased way that would tell us that we'd actually definitely got things that were different between our patient groups. And this is what we've seen. And I'm just going to again show you one data slide. We've just published our first main paper from this study. What this graph shows is the gene expression in the skin biopsies taken from the patients in the biopsy study, those with early diffuse scleroderma, later stage diffuse scleroderma, limited scleroderma, or healthy controls. And what the panel on the left is an average gene expression. So each dot represents the average gene expression in the skin for these patients. And what you can see quite nicely is this sort of spectrum going from healthy control, limited scleroderma, later stage diffuse, early diffuse scleroderma. And if you express it in a different way in what's called a heat map, where red shows the upregulated genes and blue shows the downregulated genes, and then you just ask a computer to classify all of the samples based on their gene expression. So this is, if you like, artificial intelligence classifying our patients. You can see that it makes exactly the same classification that we would in the clinic. So healthy control gene expression here, that's healthy skin. The most abnormal skin, early diffuse scleroderma at the other end of the spectrum. But if you like, a spectrum now, a molecular spectrum that follows the clinical trend of the disease. So we're now continuing to work on this, but I think it's very helpful to sort of understand what the differences are and the reason why our patients are all a little bit different. And the reason for doing this is if we can understand how the disease is developing differently, we can work out what might be the best treatments to use and when they would be best used in our patients. So I just wanted to move now to the second part of the talk and talk about treatments and really just talk about how we've been using our better knowledge of understanding scleroderma to first of all test some of the treatments that we use in the clinic. So this is some data again from a study that was supported by EULAR, but also by SRUK. This was the European Observational Scleroderma study led by Professor Herrick in Manchester, but an international study recruiting more than 300 patients with early diffuse scleroderma and looking to see how the skin changed over a year on the different treatments that we use, methotrexate, mycophenolate, cyclophosphamide, or no immune suppression. And what we could tell from this study is that these treatments do seem to be associated with improvement in the skin. You can see the skin score, which is the way we measure the skin, improving by about 20% at a group level across these different treatments, the methotrexate and the mycophenolate, which is roughly twice what you see if you don't go on an immune suppressive. Now, we do know, as I showed you in that earlier slide, that scar tissue is able to improve itself spontaneously. So there is always some improvement in the skin at a group level in scleroderma, but it's more if you're on an immune suppressant. And it's not that these patients not on immunosuppression have milder disease, because unfortunately, even in this study, we could see that more of the patients died from their scleroderma in 2 years if they were on the no immunosuppression treatment. So this really supports the use of immune suppression, but we're not curing the disease. We're sort of perhaps slowing it down a little bit. But we are impacting it. And again, I just wanted to summarize that, because when we look at the lung, we also use these immune suppressors for treating the lung fibrosis in our patients. The best data really so far have come from cyclophosphamide studies. We've done them in the UK, but mainly the studies from North America have been very helpful. So these are the data from the first scleroderma lung study in the United States. A study of cyclophosphamide, a powerful chemotherapy, taken for a year. But what you can see is if you take the cyclophosphamide for a year, your lung fibrosis, shown here on a CT scan, improves. Here you can see the sort of blue and yellow going to a much less extensive disease after a year. It improves on cyclophosphamide, but unfortunately got worse if you had been randomized to a placebo. So we think that these cyclophosphamide can really help slow the progression of the disease. But of course, it's a toxic medication. So the next scleroderma study that was done was the second scleroderma lung study. And this was a drug to see whether mycophenolate, mofetil, a standard drug that we use for scleroderma skin, might also work for the lung. And indeed it does. So here you can see the outcome of patients treated with mycophenolate or cyclophosphamide showing pretty much the same improvement in lung function over 2 years, but with a much better side effect profile for the mycophenolate, as we would have predicted, a much better tolerated drug, far fewer problems with white blood cells and abnormalities like that. So this has helped inform our treatment. But again, we know these drugs are not curing the disease. And so the question really is, can we use that better understanding of scleroderma disease process to sort of target therapies and develop new avenues that can maybe build on top of what we're seeing with our current treatments? And so we can think about that in multiple levels. We can think about trying to understand the organs that are affected, the lung, the heart, the kidney, the processes, the way the cells have gone wrong, if you like, in scleroderma, or what's gone wrong actually within the cell, and actually try and normalize those abnormalities using advances in biology to do that. And this isn't science fiction. We've actually been able to do that, I think, for some of the complications of the disease. And I'm going to share those results with you. So I'm going to focus first on one of the lung complications that we see, which is pulmonary hypertension, because over the last 20 years, there's been major progress in treatment for pulmonary hypertension. And then I'll come back and think a little bit more about lung fibrosis that I've already addressed a little bit with the cyclophosphamide studies. So pulmonary hypertension is now a treatable complication of systemic sclerosis, which is wonderful because about 1 in 10 patients with scleroderma can develop pulmonary hypertension. We now have more than 11 licensed therapies working on different disease mechanisms that can be combined together and improve outcome. So in 2001, when the first oral therapy became available, bosentan, this was a really landmark time for managing scleroderma. And here we can see what happened to our patients at the Royal Free who had pulmonary hypertension over the 5 years once we'd got bosentan available compared to the 5 years before we had it available, when we didn't have any really effective oral therapies. And you can see this is the survival curve for pulmonary hypertension in scleroderma. It was absolutely dismal. So less than half of the patients were surviving 2 years after the onset of their pulmonary hypertension. This had risen to 3/4 of patients once bosentan was available. But this was not a sort of controlled trial. It was just our experience. But the trials have supported this. And so now very large trials have been performed that really confirmed the benefit of all of those treatments I showed you for scleroderma pulmonary hypertension to improve survival, to stop disease progressing as fast. And in fact, we've now really proven that if you combine treatments early on, you can really improve outcome. And this has really come full circle. So earlier this year, I was delighted to write an editorial sort of supporting an important analysis that had shown that if you combine all of the data we have now for scleroderma pulmonary hypertension, you can show what an improvement in survival has been achieved with combinations of treatment. So what about lung fibrosis? So I showed you what we could achieve with immunosuppression, some benefit for the lung fibrosis, but now we have a targeted therapy available, nintedanib. So nintedanib, or Ofev, is a treatment that's been approved for a few years for other forms of lung fibrosis, such as idiopathic pulmonary fibrosis, but it's been shown in a large clinical trial that it also works in scleroderma lung fibrosis. This was published a couple of years ago now, and it's a landmark study, more than 500 patients recruited. And what it showed was that just as in other forms of lung fibrosis, if you're on nintedanib, which blocks some of those key pathways that I showed you are activated in scleroderma lung fibrosis, that you slow the progression of the disease. The lung function doesn't decline as much over a 1-year period. But what we also did in this study was that we actually allowed patients to be on immunosuppression with mycophenolate. So we knew they were getting benefit from that. And the question was, were they getting more benefit from being on nintedanib as well? And it does look like that's true, because in those patients that were on neither nintedanib or immunosuppression, there was quite a large decline of more than 100 mils of lung function over a year. But those patients who were on both treatments had the smallest decline of just 40 mils. And you can see here what the mycophenolate does essentially is it just moves the curve of decline upwards. And so what this tells us is, just like in pulmonary hypertension, if we combine drugs that work by different mechanisms, we can likely improve outcome. Another drug that's sort of targeting some of the biological processes in scleroderma is targeting a protein called interleukin-6, or IL-6. Now, we're very excited about this at the Royal Free because we led some of the work that first suggested that IL-6 might be important as a driver in scleroderma, because what we found was that patients who had high levels of this protein, an immune protein in the blood, had a poor improvement in their skin and a poor survival. And we knew that it was expressed in the lung and in the internal organs. So we worked with our colleagues at the Brompton Hospital, Elizabeth Renzoni and others, and Elizabeth is going to speak to you later today. And we showed that if you had high levels of IL-6 early in the disease and you had lung fibrosis, it was also more likely to progress. And all of this, a few years later, allowed us to test the idea, if you like, that blocking IL-6 might block progression of lung fibrosis in scleroderma patients. And we've done 2 trials now, supported by Roche, who we're very pleased engaged with us on this research area. And what has been shown is that tocilizumab, which blocks interleukin-6, a drug that's already used for treating vasculitis and arthritis, also completely blocked the progression of lung fibrosis in this group of patients with early lung disease in scleroderma. So that's very important. And in fact, we were able to show the same thing that had been seen for cyclophosphamide, that you got really good improvement in the CT scan on tocilizumab compared to patients on placebo in this one-year clinical trial. And when you analyzed it by a computer, there was a highly statistically significant benefit for the lung. And on the basis of that, I'm delighted that the FDA, the North American drug regulator, has now approved tocilizumab alongside nintedanib as a treatment for lung fibrosis in scleroderma. And it's being considered, I know, by the European health authorities, and hopefully we might also get an approval. But I just wanted to sort of talk a little bit about the new drugs that are now emerging, not just the sort of repurposing, if you like, of drugs that are already shown to be effective in other relevant diseases. So one of these is a very exciting drug that targeted two other proteins produced by the immune system, interleukin-13 and interleukin-4. So Sanofi, a drug company based in France, had developed an antibody that could block these two proteins. And we were delighted, therefore, that we could test this in a clinical trial in scleroderma. And the rationale for this is that it can block the activation of inflammatory cells called macrophages in disease states. And we think these are important in scleroderma in the skin and the lung. And what you could see, and here are the trial results for the trial that was published again just at the end of last year, that if you were on the drug called romilcimab that blocked these proteins, you had a much better improvement in your skin, particularly if your skin was bad. But just like the Census trial for nintedanib, this trial had allowed patients to also be on immune suppression. So this was important because it gave us that clue that the drug might actually be working in addition to the benefit that I've shown you from the standard treatments. And that does seem to be the case, because just like we showed you for nintedanib, that if you were on neither active drug or immunosuppression, you had the lowest improvement over 6 months, so just one skin score unit, so roughly what we saw in the ESOS trial. But if you were on both treatments, in 6 months, your skin improved on average by nearly 6 units. So this is quite a meaningful impact, and again, suggests that combining drugs could be a very important way to improve outcomes. Another drug that's been tested is abatacept. So abatacept really is a much more specific immune suppressant than cyclophosphamide or mycophenolate. It targets T cells, a certain immune cell compartment. So at a group level, this showed some trend to improvement in the skin. But what we were able to learn from this study is that if you had an inflammatory biopsy picture when you did a skin biopsy, you were much more likely to respond to abatacept and the skin would stabilize or improve. But what we also found with this study was that we improved the way that patients functioned, very important. So their ability, their upper limb function measured by a test called the HAQ Disability Index, which is very useful in arthritis, also significantly improved in all of the patients. Whatever your gene expression profile was, they showed benefit. So this is important. We hope that this might be further tested and become available for systemic sclerosis, but we're delighted that NHS in England, based on the sort of weight of evidence, have now approved this as a treatment for very severe localized forms of morphea. So this is now at least available for some patients within the scleroderma spectrum in England. So just to summarize all of the trials that have been done really over the last few years, I think there is a positive message coming, although we're clearly a long way from having anything that could be seen as a cure for the disease. We've got a trial that has led to an approval of a drug for lung fibrosis, nintedanib, a second trial that has led to approval of tocilizumab in North America, and we hope may be available in Europe and in the UK in the future. I've shown you the data for the ASSET trial that suggests abatacept might be helpful, and we've got other drugs that seem to have improved skin disease, but not everything has worked. Very disappointing results from a trial of lanifibranor, a drug that's looking very, very promising in liver fibrosis, but doesn't seem to work in scleroderma fibrosis, and very disappointing results last year from lenabasum, a drug that targets the cannabis receptors in the immune system. That unfortunately may have had an effect, but it wasn't an effect that was better than you see just with drugs like mycophenolate. So just wanted to finish by saying it's not all about trying to switch off what's driving the disease. We'd also like to try and regenerate those tissues once they've been damaged from scleroderma. And again, this is not science fiction. This is something that we're already starting to do in the clinic. And I just wanted to highlight one type of treatment that we're doing, again, because this is a research project that's been supported and being supported by SRUK. And this is fat transfer. So for a long time, plastic surgeons have become very good at taking fat from one part of the body and putting it in another, and it's used for cosmetic procedures. But what we found was that it actually seems to help scleroderma, and particularly scleroderma effects in the face. So this is very important, and we've now published with Professor Peter Butler, who's leading this work, our plastic surgeon at the Royal Free. What we've shown is that you can transfer fat from the tummy or the legs into the face, and this can improve the appearance of scleroderma, as you can see in this clinical photographs taken from our manuscript, and we've shown that with this 3D photography. But more importantly, we can improve function, mouth opening, dryness of the mouth, and so on, all seems to improve with this treatment. So we're now supported by the NHS doing a trial to further demonstrate this benefit, and we hope improve access to this very promising treatment. And we're starting to understand the biology, because what we found is the stem cells that we get from the fat, and it's the stem cells we think that we transfer that sort of help the tissues to regenerate. These stem cells are able to turn off some of those activated fibroblasts in scleroderma. And this is a treatment we can use in localized scleroderma. Here's a patient treated for a patch of scleroderma highlighted on the arrows, and you can see before and after treatment thermography showing that we really reduced the inflammation that is a sign of activity of the disease. And here you can see that we improved the appearance and function of the lower leg in a patient who got very, very severe localized scleroderma. So what I hope I've shown you in this talk today is that we are making progress in scleroderma. Patients are living longer with the disease. We're treating the life-threatening complications. But unfortunately, as patients live longer with the disease, of course, they're burdened by the non-lethal aspect, and that is still a terrible challenge for us. There's still a high unmet medical need. I haven't talked about stem cell transplantation, bone marrow transplantation, if you like, because that's a treatment that is effective, but only in a very small number of patients is it appropriate. So really what we've got to do, I think, is translate the understanding we've got in the disease back into new and better treatments, and particularly treatments that we can combine together and perhaps start to reverse scleroderma, not just stop it worsening. So I'd just like to thank all of the scleroderma team at the Royal Free and my international colleagues and funders of our research, including SRUK, and I will hand back to Sue and be delighted to take some questions.
Thank you very much, Chris, for that excellent presentation. And it's really encouraging, I think, to hear both the research that's going on, but some of the therapies that are in the pipeline. So thank you very much from that. We've had a lot of questions. Some of them are COVID related, so I might kind of keep those to the end. But one of the first questions that came through was from Suzanne, who asked whether the genome 6 features in localized as well as systemic sclerosis.
Yes, so that's a great question. And so we've done a lot of work on localized scleroderma, as have others around the world. But I think it is important because there are shared similarities with the disease, even though we always tell patients in the clinic, of course, they're different diseases. And if you've got localized scleroderma, fortunately, you're not at risk of internal organ problems, but it can still be a very disabling and severe disease in its worst forms. So the answer is yes, we do see some of those chromosome 6 associations, some of those immune genes do seem to be associated with a risk of localized scleroderma, and I think the way to look at that is that we know that our immune system is, if you like, regulated by our genes in a complex way, and so if you've got an immune system that maybe has some tendency to trigger a fibrotic or scar process, it's not surprising maybe that it can sometimes trigger a localized form of the disease and sometimes systemic. So there is a link, but as I say, these links, although they're very interesting and important from a research point of view, of course, they're not sufficiently strong that you can use them in practice or in the clinic.
Thank you. And we've got a question from Linda, who's asking, how critical is exercise for someone with lung fibrosis? Can this avoid fibrosis becoming worse over a period of time? So looking at more of the therapy, the rehabilitation, as opposed to maybe the drug side of things.
Thank you. So I am a great fan of exercise. myself, but also for patients. And I think it's really good for you on many levels. And I think the most important thing to say is that it has been shown that if you've got scleroderma and you've got impaired lung function and you've got breathlessness, overall, you can improve both the lung function and your ability to function, if you take regular exercise. And the reason for that is that in scleroderma, there's often some deconditioning. So the body loses its ability to coordinate heart and lung function and blood flow to the muscles that is so important in exercise. So in general, exercise is good for you. I don't think exercise can reverse the pathology of scleroderma, but it can certainly improve function. The caveat, of course, is that if you are breathless with scleroderma or there are worries about the heart or the lungs, it is very important first to check for pulmonary hypertension, severe lung fibrosis, heart involvement, because it could be that it would be sort of potentially dangerous to do too much exercise if you had a major problem in the heart or the lungs that needed to be treated. So I think once you've had all of the tests done, part of the general management and approach to disease should be, if possible, to take exercise.
Thank you. Now, there's a couple of questions here about COVID, which still is with us. And I think there are some, real anxieties amongst our community. So I've got a question from somebody who's, she's 14, she's got systemic sclerosis, and she was recently offered a COVID vaccine from her local surgery because she's at risk of lung disease. She said, should I still get the vaccine, even though I'm very young?
So thank you, Sue. And of course, completely expectedly, we have had a lot of concerns, and our patients have, about COVID over the course of the pandemic. We've had to look after a lot of patients with COVID, with or without scleroderma as well, in our hospital. I think fortunately we now have, the consequence of a pandemic is that at least, you can get the evidence base to sort of support statements, particularly by now where we've fortunately been able to do quite a lot of research into patients with scleroderma and how they respond to vaccines and so on. So I think I can give you a simple practical answer, which is that we would advise patients to have a vaccination if they're offered it for COVID-19, if that's part of the sort of general recommendation. And I think in the UK, we're just waiting for that final thought about whether there should be a routine vaccination of people over 12. But I think that in general, a vaccination is definitely a very protective for COVID. And I think the data would all suggest that if you have a vaccination, even if you get COVID, you're much less likely to have severe disease. The question is, do patients with scleroderma, of course, have a particular problem with the vaccine, or do they have a particular problem with COVID? So, fortunately, a lot of our patients who had COVID and who have systemic sclerosis did very well in our centre, and I think that's been true around the world. So it's perfectly possible to have scleroderma and be on treatments for that and to have relatively mild disease with COVID, but that's not guaranteed. You can still have very, very severe disease from COVID. So you certainly can't be complacent about it. And again, we would advise all of our patients to have the vaccination, just like the rest of the population. But that does then bring the point of, is it, do scleroderma patients respond to the vaccine as well, and do they have any more problems with the vaccine? And fortunately, again, we have data now. So there are going to be some presentations at the ACR meeting, which is an online virtual conference for rheumatology, which will be in November, early November. But presented there will be some studies that have looked at many hundreds of patients with scleroderma who've had the vaccination. And I can report that the data from that study do show that there is no difference in the side effect profile for patients who've got scleroderma who have those vaccines in terms of systemic reactions or local reactions, really, from the general population. So I think scleroderma patients should be reassured. The other issue, of course, is if you're on immune suppression, do you respond less well to the vaccine? And I think that is turning out to be the case, not surprisingly, that you probably do have less response to the vaccine, and therefore that's not a reason not to be vaccinated. But there is certainly still ongoing discussion about whether a break or a short interruption of immunosuppression around the time the vaccine could be helpful, and in particular, whether a third dose of vaccine would be appropriate. And again, my medical recommendation would be that if you were offered a booster or a third dose of vaccine, particularly if you were on immunosuppression, that would be sensible.
We have got so many questions, but I think we've only got time for one more, unfortunately. But we will see, for those people who've asked the questions, whether there is a way for us to, whether lots of the same questions, whether we can pull together a Q&A following this session. But this one comes from Liz, and she said, given that the disease burden is growing as mortality decreases, what research is being done into the non-medical patient experience?
So thank you. I mean, I think I give a brief answer and say we're making a lot of efforts. I mean, I think as is the sort of global community, and I think it's particularly important to highlight that. And it isn't just about medical and basic science research. It's about research that's really engaging patients to understand what the burden of their disease is and how they're impacted. So I'm sort of delighted to say that is a very active area of research. And I know that SRUK is also working on that. And I know a lot of international collaborations really looking at the impact on patients. And I think that's absolutely right. We realize every time you get one bit of the disease better, you've then got to sort of potentially tackle other areas. And I think a lot of research is being done. Perhaps it's not surprising, but the non-lethal aspects of disease are very, very challenging, I think, to understand as well as to treat. So, I think we've got a lot of work to do, but I think it's very important to be doing that with a strong engagement with patients.
Thank you. And once again, Chris, thank you so much for sharing your extensive knowledge and experience with us. Many thanks. Now, as I mentioned earlier, we've got, in addition to the presentations, we've got an exhibition space, and we've also got a health and wellbeing zone. And before we move on, we'd like to give you a little taster of one of those sessions, which is around face, mouth and hand exercises led by Will Gregory. So please sit back and relax before our next session.
Okay, well, hello everyone. Welcome to this session for SRUK, primarily for the conference in September, but the video will be able to access for long term. And I really hope that the facial stretch routine we're going to run you through on this session will be useful for you long term as well. My name's Will Gregory. I'm a physiotherapist working in the scleroderma team at Salford Royal. And we put a shout out to all of you members out there to see if anyone might like to volunteer to support us in this. And Una very kindly has volunteered some time for us to record ourselves doing these exercises together. Una, do you want to tell us a little bit about yourself and maybe why you've volunteered?
Yes, I'm Una and I live in the north of Ireland. This is something that's been very passionate. I started fundraising for scleroderma when I was put on furlough last year. So I just wanted to raise awareness in the north and even all over Ireland for all the patients, because we didn't have a support group, and when I do because of that. So I'm very proud of that, and we've got about 70 members in the support group at the minute, so it's still growing. I added one last night, so yeah, all good.
Yeah, very good, great stuff. And I think that support group function is vital for all of us, and particularly if it's an area where it wasn't set up before. That's brilliant that you've been able to throw yourself into that. Yeah. So on this session, we're going to ask you to throw yourself into something different, which is having a go at these mouth exercises. So these are evidence-based from the research, and probably for about 20 years or so, these have been suggested and tweaked, and every bit of research that's been done shows they can help. We know the mouth is quite often affected in scleroderma, and where the skin tightens, you do lose movement with that. We can't promise you'll get all the movement back, but we know doing these exercises on daily routine, most people get some of the movement back. And, if your mouth doesn't open as well as it should do, there's a few things that you struggle with. And Una, we discussed this. I don't know if you want to come in with your experience.
Yeah, well, it's mostly for the dentist. I always blame his hands because they're too big. I told him I need a female dentist, but yeah, he can't get all his tools and stuff. I actually got a tooth extracted and it turned the side of my mouth. So it's quite a handling to get to the back of my mouth. But hopefully with the fat transfer and with exercises like this here, it'll improve and it'll get better for them.
Yeah, and I think that's in the top 3 of what's been found, talking to lots of people around the world with scleroderma. The limited mouth opening certainly makes your dental care more challenging, but also it's been suggested it can make eating tougher. It can even make talking a bit tougher, depending on how tight the mouth is. So really something nice to focus on. And it's been found if you do this stretch routine 3 times a day, you'll normally gain a good amount of movement back. I'm yet to meet anyone who's committed to 3 times a day for the rest of their life, but even once a day is a nice little habit. And you'll see it takes maybe 5 minutes once you know the routine. You can do it anywhere. There's no equipment required. If you're watching this, please do feel free to join in with the unusual facial positions myself and Una are going to attain for you. Once you've learned the routine, don't feel you need to come back here to be taught it again. You can go off and try it by yourself, but bear with us as we take you through the next 10 minutes.
Well, if you liked what you heard in that kind of taster video, or if you missed it, don't worry, you can find the full session by visiting our health and wellbeing zone in the exhibition space. And now we're going to move on to our next session. I think many of you may have heard that people saying that data is like the new oil. The commodity that is going to be a game changer for many aspects of our life, and particularly medicine and research. But what does this actually mean in terms of benefits to us now, and what are the challenges? I'm very pleased to introduce Dr. Meghna Jani, who's a clinical scientist at the University of Manchester and a consultant rheumatologist at the Salford Royal Hospital. Dr. Jani will address the topic of, can patient data save lives? But once again, if you have any questions, do put them in the Q&A, and we will try and answer as many of those as we can at the end of the presentation. So I'll now hand over to Dr. Jani.
Thanks very much, Sue, for this kind introduction. So thank you very much to the organisers also for this invitation to speak to you today. So as Sue mentioned, my name is Dr. Meghna Jani. I'm a NIHR clinician scientist based at the University of Manchester. And just very briefly about my role, I'm predominantly interested in electronic health records and drug safety, but I'm also a consultant rheumatologist at Salford Royal Hospital. Now, Salford Royal Hospital happens to be a global digital exemplar site, which means that it's one of the most digitally advanced trusts in the country. And as part of my role, I also work very closely with the Health E-Research Centre, which uses patient data for a number of research projects to improve patient lives, and also work closely with HealthText, which is a UK text analytics network that I'll talk a little bit about in my talk as we go on. So what exactly do we mean by health data? So health data supports clinical care, and also has huge opportunities to support research, service provision, quality improvement. And a number of you will have heard about the term data saves lives. And this was actually a term that was initially coined by the FAR Institute, which is now called HDR UK, back in 2014. And this was essentially a campaign that was started with a simple goal of promoting the positive use of data in health research on social media. So what do we mean by patient saves lives in 2021? So this is a really nice video which has been made by Understanding Patient Data, which I thought would be useful to set the scene in terms of what I'm going to be covering within this talk. So I'll just play this video. Hopefully this works.
Human society is built on our ability to share and pass on information. It has allowed us to progress from the Stone Age to the Space Age. Today, in the age of digital communication and high-tech research, sharing data is more important than ever before. And this is especially true in healthcare. When the NHS was founded in 1948, things were quite different. Our medical records lived in dusty drawers, locked away in darkened corridors, and seen by very few, despite the need. Data held anywhere in the health and care system must be stored securely with controlled access. There are strict rules about how data can and cannot be used. Data is provided in the most anonymized way possible. with robust legal contracts. These safeguards are in place to protect privacy and ensure data is shared responsibly. From improving patient care to speeding up diagnosis and researching brand new treatments, data saves lives. It could one day save yours or the life of someone you love. To find out more about how patient data is used and your choices, visit patientdata.org.uk.
Okay, so despite all of the opportunities that were highlighted within that particular YouTube video, we know that there are a number of limitations, however, that come especially from the availability and the quality of the data from the NHS. And musculoskeletal research especially exemplifies many of these data problems. So the first challenge, so despite the opportunities of linkage, unfortunately, data between primary and secondary care and pharmacy data and social care are not necessarily linked for research purposes, and this can be a huge challenge. Data often can be unstructured, and so this is your typical clinic letter that you might get copies of through the post, and this contains very useful information about the patient journey, about their diagnosis, medications, etc., but is largely an untapped data source at present. And unfortunately, the patient perspective is often missing from routinely collected data, but there are new opportunities of how this could be incorporated in the future. So what exactly does patient data mean in 2021? So a number of you may be part of drug or patient registries, which have been in existence for the last few decades. Clinical trials, of course, are incredibly important to assess drug efficacy and interventions, more recently vaccine efficacy. Electronic health records is essentially what we mean by the bulk of big data and healthcare data, which I'll talk about a little bit later. Mobile health devices and wearables are new opportunities in the last few years, particularly with massive opportunities with patient monitoring, remote monitoring, and measuring adherence to certain medications, for instance. And social media data, in fact, is a potential source to help us understand the more holistic patient experience outside of just electronic health records. So I'll provide some examples of where this has worked well and where this can be going in the future. So how have some of these challenges been addressed in recent years? And actually COVID-19 has been a useful platform to try and address some of these data challenges. So I thought I'd highlight this study, which was a very important study back in July 2020 when it first came out. So this was essentially a collaboration by Open Safely, which was established by Ben Goldacre's team at the University of Oxford. So in the 6 weeks post-COVID, this team built an entirely new secure analytics platform in the NHS. And for this particular research question, which was to assess the factors associated with COVID-19 hospital-related death, of course, a really important research question at the time, they analysed electronic health records from 17 million UK adult patients. Their primary outcomes, their main interest was obviously death in hospitalised patients who had confirmed COVID-19 using a swab test. They linked GP records to inpatient hospital death notifications, as well as the Office of National Statistics data as part of this analytical platform. And importantly, they weren't able to just assess the effect of comorbidities, but also the severity of some of the baseline comorbidities, for example, asthma, diabetes, and cancer. So what did they find? So this was one of the first studies in the UK that showed an incremental risk of death due to COVID-19 when it came to age. And of course, this study and other studies similar to this have fed into the vaccination priorities by the NHS, where, as you probably know, back in December 2020, it was people over the age of 80 and over who got priority with the COVID-19 vaccinations because they conferred the highest risk. They also found that obesity was associated with almost a twofold increase of COVID-related death. And again, depending on what obesity class people fell into, this risk was increased. And they also found that non-white ethnicity was associated with an increased risk of COVID-related death. And this again has been replicated in several studies subsequently. What about comorbidities? Well, they found that diabetes, for example, was associated with increased risk of COVID-related death. But importantly, if people had uncontrolled diabetes, this risk was much higher. They looked at certain autoimmune conditions, not all, because of numbers. So they looked at rheumatoid arthritis, lupus, psoriasis. This conferred an increased risk, as did other immunosuppression that was captured within the GP record. And a number of other comorbidities and other conditions, for example, chronic lung disease, heart disease, liver disease, people with previous stroke or dementia, and people with reduced kidney function had an increased risk of some of these outcomes. So the next sort of big research question was around long COVID and what happens, what's the risk of long COVID after hospital discharge, and what does this mean for the post-pandemic era, which is what we're facing at the moment. So this is a more recent study that was published in 2021, and here they looked at estimating the excess morbidity after severe COVID-19 disease. They used electronic health records, this time from a bespoke GP database, and linked them to hospital episode statistics, which come from your discharge summaries. So they matched these two essentially non-COVID controls, and they identified as part of this study around 48 patients for inclusion in the study. And so what did they find? So strikingly, about a third of patients who were discharged from hospital following COVID-19 were readmitted, and unfortunately 1 in 10 died following discharge. And importantly, they also found that following discharge, patients who had COVID also had higher risk of new lung disease, which was 6 times higher than matched controls. Major cardiovascular disease, as well as chronic liver disease and chronic kidney disease, were higher in people who had been admitted with COVID-19 in hospital. And interestingly, these risks appear to be higher in those who are less than 70 and also those of non-white ethnicity. So again, non-white ethnicity appears to be important both as a risk factor for patients who are admitted to hospital and death due to COVID, but also issues with long COVID following off hospital discharge. And the third example I wanted to use was around the risk of blood clots with COVID-19 vaccines, which you'll know is a very topical issue at the moment. So this is a study that was published just a few weeks ago in the BMJ, fairly hot off the press. And here they used data from 19 million people in the UK who had their first vaccine dose and linked them to GP records and national data on deaths and hospital admissions. And this was one of the largest studies of this kind. Here they used something called a self-control case series design, which is essentially comparing exposed and unexposed periods within the same patient. And this is a fairly standard type of methodology in vaccine epidemiology. And they essentially evaluated outcomes 8 to 28 days following the first dose of either vaccine. So 19 million people who had the Oxford vaccine, or 10 million people who had the Pfizer vaccine. So I'll just talk you through what they found. So here the purple line represents the Oxford vaccine, so the Chalox-1. The orange lines represent the Pfizer vaccine, and the pink lines represent those who developed a COVID-19 infection. So here where you can see 1 is the line of no effect. So anything essentially that crosses 1 suggests it's not significant. And so closer to 1 means that the risk was lower, and further away from 1 means that the risk is much higher. And here what they found is that there was a slight increase in some of the thromboembolic events seen 28 days post-vaccination, both actually with Oxford vaccine and the Pfizer vaccine. But importantly, the absolute risk was very, very low. But the most important finding is the risk of all of these blood clot type events was considerably higher. So that's the pink lines that you see here following COVID-19 infections. So actually these risks, all of these blood clot type events happen in COVID-19, and the risks are higher if people have COVID-19, which was a really important finding. So I've talked a little bit about electronic health records and in terms of structured data, but what about unstructured data collection? I'll talk about the differences of those in a minute. So back in April 2020, the government and the British Society for Rheumatology issued guidance for people within the rheumatology community that should be shielded. And essentially all of the rheumatologists within the country received this letter from the British Society for Rheumatology, where they announced that people who were at high risk needed to self-isolate for their own protection. However, who constitutes high risk wasn't completely clear, but this was advised as such by the British Society of Rheumatology. This is a sort of fairly complex grid, which was based on people's medications, on their comorbidities. And there was another type of grid that also had a stratification score. And depending on which score people use, people may or may not have necessarily fallen into the shielding guidance. So I'd be interested, as part of this particular community, what people's experiences of shielding were. So Dave, if you could administer the poll, and we could perhaps give people a couple of minutes to fill it in. So it looks like people are still voting, so we'll just give people a minute or two. So Dave, I can't see the results yet, so are you okay to publish them in about another minute or so? So I can't still see them. Okay. Yeah, well, is there any way that I can see that? Yeah, it's just like they're just too small to see anything. I can see some bars, but I can't. It's too small. Okay. Yeah. Okay, that's great. Yeah. Okay, so unfortunately, I can't see the full results myself because the way this is set up, but I understand that the majority of people actually didn't receive a letter, but tried to shield anyway. And a small proportion of people, so 4%, received a letter, but didn't shield. And about 51% of people received a letter to shield and followed shielding guidance. So that's really interesting. So I wonder what people's experiences were of shielding, but certainly Versus Arthritis did a survey, which was published in July 2020. And they found that there was really widespread confusion about shielding. So nearly half of the people who made the decision to shield themselves without receiving any government guidance, and that's actually reflective of what we saw today in the poll. And 28% were advised by healthcare professionals and 20% were advised by their friends and family members to shield, which is really interesting. And definitely patients that I've spoken to, patients were often asked to self-classify themselves in other hospitals if they needed to be shielded. And one of the pieces of feedback was that there was no transparency of why some people needed to shield and some people didn't. So it wasn't like you got a personalized letter to say that you fit the category for shielding because you're on a particular type of drug, because you've got systemic sclerosis, because you've got existing health conditions that affect your lung. So that was something that was lacking, and of course had a huge impact on patients' lives for the next 6 months when they were asked to shield by the government. So this sort of brings me on to what we try to do to tackle this particular problem. And before that, I thought it would just be useful to just tell you what the differences are between structured and unstructured data, which make a difference as to how we can analyze some of this work. So structured data is essentially where GPs or healthcare professionals have a drop-down menu, and you can select essentially what the condition is, what the medication is, that sort of thing. And all the information that I presented before with electronic health records is in the structured data format, so it's easy to analyze when it comes to research. However, the challenge is that a lot of hospital data especially is very unstructured, which is essentially narrative texts in a letter. So to give you an example, here's some unstructured data which has very useful information about the patient's journey. So the allergies, for example, the patient being on penicillin, being on particular types of drugs for their pain, their hypertension, all the comorbidities, their family history, etc. But this information is very difficult to pull out when it comes to using it for research. However, there is value in narrative text because that's traditionally how clinicians communicate with each other. So how a hospital physician will communicate with their GP. Not everything can be captured in these pull-down menus or checklists, so not everything can be structured. And the other challenge is that the codes and terminologies in structured data can sometimes be quite difficult to navigate, even for experts. So this is sort of the life cycle of an outpatient clinic letter. So you go to your healthcare professional for your clinic appointment. They'll make a dictation, which is then typed by a transcriptionist or their secretary. And this then generates this type of letter, which you may get a copy of through the post, but certainly goes to your GP. And this is what it would look like in Salford Royal Hospital. This is all dummy data. I'm not disclosing any patient information here, but essentially it's in semi-structured format with information about diagnoses, non-neurological diagnoses, medications, and a lot of detailed texts about the assessment. The challenge is that a lot of information that gets captured in hospital records, so for example, certain immunosuppressants like cyclophosphamide, certain biologic drugs, are simply not captured in the GP record. So this information has to come from the hospital letter, which is unstructured, and therefore that was the reason why clinicians and physicians had to look through all of their patients' letters to see if they met shielding guidance or not, and fulfill the grid that was published by the BSR. So to fulfill the shielding guidance, we needed information about patients' drugs, especially their time, the dose, the duration, their start date. So to give you an example, one of the shielding criteria was if people were on steroids, more than 20 milligrams per day for more than 4 weeks. However, if you're trying to develop an automated algorithm, 4 weeks from your last clinic letter requires information about when the current letter is, when that patient was seen, are they still on that particular dose? It's obviously harder then to decipher whether or not that patient should be shielding or not on the basis of a one snapshot letter. And so this is where text mining comes in, and the work that we're doing with the National UK Health Text Analytics Network. So text mining essentially means how to automatically understand this narrative text in clinic letters and others in natural language, so in the simplest possible language. And you might have heard of these terms called natural language processing, NLP, text analytics, which is essentially an artificial intelligence-based solution that helps computers understand, interpret, and manipulate human language. And so this is the type of sort of technology that we're using to understand the data from hospital letters. So to give you an example of what we would do, this is a sample clinic letter. We would remove any patient identifiable information such as their date of birth and their name or their hospital number. The diagnoses would be passed through a specific algorithm that we've developed, and this allows us to map each of these conditions to a dictionary called SNOMED CT. Essentially, that's a code to each diagnosis, and it's very well used in the NHS. We then devised a separate algorithm for medication use, and this then allows us to capture the dose, the frequency, the date that the patient was prescribed that particular medication. And again, this is much more of a work in progress. But whilst this all sounds fairly straightforward, that you just run a couple of algorithms on some clinic letters, we found that there were a number of challenges in trying to do this. So one of them being that rheumatological diagnoses are actually defined in lots of different ways, depending on the clinician or the healthcare professional. So it might be called rheumatological diagnosis, it might be called diagnosis or working diagnosis, there might be lots of typos. And similarly with medications, they're captured in lots of different ways in the clinic letters. So we had to sort of define more than sort of 4,000 sections within the letters to see whether or not they fulfill the diagnoses and medication category. And again, identification of medications and start and stop dates have a number of challenges as well. So for example, again, using the steroid example, if the patient was on a specific dose, but then asked to reduce on a specific day, on alternate dates for 2 weeks, and then reduce to 15 milligrams per day, how does that relate to what that patient is on that particular day? So there are certain assumptions that need to be made when you're using these type of algorithms. Similarly with infusions, if patients on rituximab or cyclophosphamide, when that last cycle ended and 6 months after, if they still fall into the exposure period for shielding, can sometimes be a little bit complicated to define. So we devised a number of different algorithms around this work, but we realized that this is a huge issue in healthcare, and it really needs to be tackled in a systematic way across a number of different hospitals. So as part of this, we applied for some funding from UKRI and the EPSRC, and we were successful in getting this particular grant, which is just under £1 million. The lead of this is Professor Goran Nenadic, who's one of the computer scientists that we work very closely with. Myself and one of the digital epidemiologists that I work very closely with, Bill Dixon, is involved as part of this grant, as well as a patient partner, as well as industry, as well as the Salford business intelligence teams. So this is starting in the next month, and we're planning on essentially tackling this issue over the next 3 years. The outcomes from this will be a governance-led infrastructure, which will allow us to access outpatients letters for secondary use, not just in Salford Royal, but also in other hospitals. It'll allow us to develop automatic algorithms to extract a range of features from clinic letters, not just medications and comorbidities, but ideally disease activity scores and quality of life measures, which are really important, of course, to the patient. And also impact case studies, which will include using the outputs from this work for service planning, for research, and also to improve the transparency of similar exercises to shielding if that's needed in the future, so that on an individual level, people might know why they've been asked to shield and what specific criteria they meet, so that they can make a decision as to whether or not they wanted to shield. So finally, I thought I'd just briefly talk a little bit about the absent patient perspective from routinely collected data and the opportunities around this. So in the last couple of years, of course, all of you will know that mobile health allows opportunities for remote monitoring of chronic conditions in between appointments. I don't need to let this audience know that systemic sclerosis related digital ulcers are often painful and disabling, but often the size and severity of these ulcers are measured subjectively in a clinic setting. So this is work that's been led by Professor Ariane Herrick, who works at Salford Royal with me, and she and her team have essentially used the opportunities from wound healing, so software called digital planimetry, and applied this to digital ulcers. So using the work that they've done previously, they essentially built a feasibility study, which allowed patients with systemic sclerosis and those who had digital ulcers to photograph their lesions using smartphone cameras. And this is fairly early work, but essentially what it shows is proof of concept that this digital planimetry style software on images collected from patients could track lesions as a marker of progression or healing over time. And as part of the study, patients were asked to photograph their lesion using their smartphone camera for a maximum of 35 days. And what they found is actually there was excellent patient engagement as part of the study. So photographs were taken approximately 2 out of 3 days, which is great. And importantly, the collected photographs were of analyzable quality, which means that these photographs can potentially be used for other purposes, such as clinical trials, of course, for research and for clinical purposes. And this has actually led to a sort of a platform for patients, not just with systemic sclerosis, but also with other conditions who wanted to photograph, rashes or various aspects that might be useful for the physician to see. And this has been used during the pandemic, especially during the remote consultations that we've had to implement as part of our clinical care. And so finally, the other aspect of patient-generated data is social networks. So social media especially provides a valuable platform for patients living with chronic conditions to discuss their medication experiences, their holistic impact, seek peer advice and support, but also gives people the opportunity to discuss things that they may not necessarily feel that they've got the time or feel comfortable discussing with their healthcare professional. So some of you will know and maybe even be members of Health Unlocked, which is Europe's largest social network for health, which has more than 1.4 million members, more than 500 patient communities covering over 250 conditions. So as I mentioned previously, I'm interested in drug safety, and you may have heard about this opioid epidemic that's affected North America in a big way. And so there have been concerns about similar issues affecting the UK in the last couple of years. And so with that as a background, we sought to understand better the perceptions of opioid use in people who use these drugs for musculoskeletal conditions. And this was done using posts from people who had provided consent on Health Unlocked, and this included the systemic sclerosis community. So what we did is that we used both a thematic analysis as well as natural language processing to come up with to discern a number of different themes within the posts in social media. And almost unsurprisingly, one of the big things that people discuss on social media in relation to opioids was side effects, but people also discussed things like ineffectiveness to these drugs, discussing alternatives to these medications, particularly use of CBD oil, turmeric, probiotics appear to be very popular. And interestingly, people were also trying to withdraw from these medications themselves. And some of them were actually experiencing withdrawal side effects themselves, but not necessarily realizing that that's what they were going through. And then smaller themes also appeared to be around effectiveness of these drugs, because of course they can be effective for some. And then some people were discussing issues around not being able to access opioids in a timely way and seeing if they can access illicit opioids because they were in so much pain. So really interesting themes that we wouldn't be able to capture within routine clinical care. The other aspect that is useful from a side effect perspective, which again is just not possible using electronic health records at the moment, is capturing the nature of these side effects. So for example, someone discussing about how opioids turn them into a lethargic zombie and couldn't string two words together. Rare side effects were also mentioned. So for example, people taking tramadol and experiencing seizure that led them into hospital. Again, this is something that is actually in the patient information leaflet, but we just don't really hear very much about. And it's not something that people necessarily get consented for before they get started on the drug. Also, lack of awareness of the side effects and dependency issues also was a big sub-theme within side effects that people discussed. And also the impact of the side effects on quality of life. So taking opioids, for example, was only giving me side effects. This person couldn't sleep, they couldn't type for any length of time, and then couldn't concentrate long enough to read. So really important quotes of how this really affects people in real time, not just the fact that they had a side effect or not. And the other interesting thing we found was that, of course, these drugs are associated with lots of different side effects, but there are certain ones that seem to affect patients a lot more, but are not necessarily discussed in the public domain as much. So people often discussed aspects around brain fog, people developing headaches, problems with concentration, temporary memory loss, and severe constipation, which actually there really isn't that much research about. And so this has actually helped us sort of decide which particular research questions to prioritize in this field, and we're advertising a PhD studentship on the basis of some of the work from social networks. So just an example of how social networks and social media data can help inform future research questions, harnessing the patient perspective on a much bigger scale. So hopefully I've given you a snapshot of what patient data means in 2021. So patient and drug registries are of course incredibly important as a clinical trials. There are huge opportunities now with electronic health records, which are constantly emerging. Mobile health devices and wearables, of course, are an excellent opportunity as well. And this will again evolve in the next few years. And social media data, which allows us to capture the holistic patient experience. So in summary, as I've mentioned, electronic health records and routinely collected data have huge potential to inform research and improvement in patient care. There are still challenges that exist in terms of linking data sources, for example, primary and secondary care, as well as emerging data sources like patient-generated data. So for example, data from your smartphone or your wearables, such as your smartwatch, might not be integrated into the electronic record yet, but there are certainly efforts to make this happen. There are new opportunities. So my colleague Will Dixon is leading a program of work called the Assembling Data Jigsaw program, which is aiming to do exactly this on a bigger scale in musculoskeletal research that I'm lucky enough to be part of. It also allows us to answer questions that have been previously difficult to answer. And ultimately, the aim of all of this work and any research that we do is to improve patients' lives and the quality of their life in the future. So I'd like to thank all of you for your attention. I'd also like to thank my colleagues, especially Will Dixon and Goran Nenadic, who I work very closely with, a number of people who've helped with the unstructured data collection work that I've mentioned, and also my funders. Thank you for your attention. I'm very happy to take any questions.
Meghna, thank you very much for that fascinating insight into the world of data and its power to transform research, but as well also the healthcare services. So that was great. And actually the questions were coming in, but as you were going through your slide deck, you were answering those. So there was a question about social media. You did that full circle. But there is just one question I think we've got time for, which is somebody's asked, are there risks to patient privacy through sharing data? I think that's something that a lot of people are concerned about.
Of course. So I think that's a really important question, a really topical one. As I was trying to allude to before, I think everything that uses patient data is very mindful of that, not just because of the new GDPR rules, but because we recognize that patient data is very sensitive, especially clinical records. So what I was trying to allude to previously with the electronic health records, any information that's used for research is completely pseudonymized. So the researchers don't have any idea of who those patients are on an individual level. The data are all analyzed in a secure analytics environment. So in the University of Manchester, there's something called a trusted research environment, which is you need to have very special access to it. People who access certain types of data need to go through quite robust training, and there's a test at the end of it. So there are lots of provisions to make sure that patient data is treated sensitively and not shared to people that it should be shared to. And we try to, of course, get patient consent as much as possible with any patient data that we use in the first place.
That's great. Thank you very much indeed.